Hello?
Salam
Yeah,
doktor.
good afternoon, doctor.
Alright. Hello.
Assalamualaikum doktor.
Hello? Boleh dengar kan?
Yes, doctor.
Boleh doktor.
Alright. Can we start now?
Yes, doctor.
Alright. Hmm. Eh. Boleh nampak ke? Hello?
No, doctor. Apparently, we couldn't see anything.
Okay, sekejap eh. Hello? Boleh nampak tak? Hello?
Boleh, doktor.
Kan
Okay.
doktor.
So, dia punya topik for today is central nervous system. So, yelah. I think I go basic first lah kan. Electromagnetic spectrum, X-ray. Dengar tak? Dengar kan?
Ya, doktor.
Okay. The what do you call that? The electromagnetic spectrum lah. I mean, gamma rays is one of the dangerous, and then X-ray, because starting from here, we call ionizing radiation lah. Yang before this is non-ionizing radiation. So macam microwave, your infrared, your white light, spectrum light tu is consider non-ionizing radiation. Start ultraviolet, dia dah jadi macam 50-50 sikit. And then this is how the X-ray tube produce. Ni basic of X-ray lah, basic of radiology. Go beyond sikit. Okay, this one is the X-ray tube. Okay, and then this is the detector tau. So patient above. So the creation, how to create is via macam the anode, and then dia pergi the electron beam into the cathode, and then cathode ni usually tungsten tau, and then when the electron produce, dia bombard the tungsten punya target, and then X-ray will produce. Dia quite complicated sikit, tapi I think for your this one is enough lah. So this is the image produced, okay? The X-ray tube, and then the detector on the other side, and then the patient. And then the thing that lagi dekat dengan panel, dia akan nampak dulu. I mean, kalau the heart is dekat, and then heart to become brighter lah. Dekat dengan what they call that flat panel, okay? This is just to show you the detector ni lah for the X-ray. And then ultrasound is different. Ultrasound is like the name suggests, sound is using sound wave lah. But at ultra ni lah, selalunya kita panggil, I mean, the one normally that we use is the 12 megahertz, 12,000 megahertz macam tu lah. So dia ada compression of the sound, and then the rarefaction, and then this one is the molecule udara or molecule yang kita dekatkan lah. It's like this one. The thing that vibrate is piezoelectric, and then dia ada protective layer, and then the transducer. This whole thing what we call transducer lah. And then normally we use for intracranial for pediatric patient lah. We want to see the third ventricle, lateral ventricle, the brain structure, sometimes cardiac practices. Most of the time kita nak tengok lateral ventricle patient. And then for sometimes for adult, we want to see the cranial artery, carotid artery. Sometimes you can see macam clot formation, clot ataupun the atherosclerotic plaque dalam this one lah. Selalunya kita minta if the patient had multiple stroke on one side, and then the patient punya heart is normal, meaning dia tak ada AF, dia tak ada irregular rhythm, so the clot probably being created at the carotid. You all okay tak? I cakap je, sembang je, okay kan?
Okay, doktor.
Okay, doktor.
Okay, this one is what we call transcranial Doppler. It's being used also in UPM, tapi bukan I yang buat lah. This one normally is done by the neurologist. Okay, we go for CT scan. The similar process CT scan ni, like X-ray. Yang satu ni selalunya yang kecil ni, this one is a X-ray tube, and then this one is the detector, and then all this one is the radiation. I mean the radiator, radiator for air cooling lah. And then most of the time dia bukan pakai air cooling sangat, dia pakai oil apa semua lah. Dia pakai different lah. So the X-ray on steroid jugalah. So this is the third generation. They once they rotate, kan, you imagine that like this, they rotate. So they move the detector. The fourth generation they move. The X-ray tube saja move, and then the detector, a lot of detector lah. Sometimes sampai beribu. So this one just to show you that what we have in UPM, kita panggil dual source. Dia ada X-ray tu, tube tu dua, tapi dia detector tu dia gerak sekali. Dia macam hybrid sikit lah. Dia bukan macam the fourth generation tu. Alright. This one just to show you MRI. This one yang macam, very big MRI. This one for study purposes. It's not the usual one. Patient pun kecil je. This one 9 Tesla one. So normal MRI machine is like this. And then along is the magnet, and then this magnet is sometimes we use in our HUPM, kita punya pakai 3 Tesla magnet. Okay, and then there the radio frequency coil. Okay, I'll show you later on. Okay, this one normally what we measure is the proton in most of the time is fluid. They're the ash, proton. So in the because our body 80% or 70 to 80% contain fluid. So and normal at rest the fluid dia tak ada tak ada precession ending, dia tak ada what they call that, dia tak ada arah, no direction. And then once we get the patient into the magnetic field on, and then they start to align to one direction, and then we give the radio transmitter, RF kita call. RF tu kalau you perasan, kalau dalam MRI kan, you ada bunyi tet. Kalau you perasan lah, I think, have you been to our radiology department? Belum?
Bin.
Kan? Kalau you perasan, MRI machine dia quite noisy compared with the rest lah. So dia ada tet and the gap and the tet and then gap. Most of the time the tet one is the radio frequency that transmit to the patient. It's just dia bunyi lah sikit. And then when yang dia punya pause tu, actually the transmitter off, and then tenaga tu dia cuba patah balik and then re-emit the radio wave. So split second tu dah ada 1 or 2 image tu. You understand what I'm saying? Okay. Faham tak? Faham pun bawa faham je lah. Alright. So this is angiography, right? I think you've been there. I mean, few of you. So ours is in SUPM is by plane. Again, this is X-ray on steroid. This one is the X-ray tube. Okay. Again, like I say, X-ray tube the kecil, and then the detector is large. Okay. Macam ni. So just to present a few case of ours, 64 years old, MRS kosong. MRS kosong meaning the patient can go on his own, do all the daily activity independently. Okay, the patient had diabetes and hypothyroid. BP was on, dia punya onset is 9:30, and then patient is from hypersostas sedang, and then BP was 220 during the stroke. Most of our experience kan, waktu kena stroke ni BP memang high. BP memang high. Somehow, the brain, when you brain to didn't get some blood supply, then BP shoot up. So, and then assessment by our neurological colleague. So ni kita ada panggil NHS score. Mana ni? Ni 15. So anything that more than 6, or by right more than 6 kita kena treat lah. So and then bila ada hemi-neglect ni, meaning that the patient had LVO, large vessel occlusion. So this one just to show you dia punya time, because time is brain. So kita monitor time. So yang paling lambat sekali family discussion lah during that time. I mean payment is an issue. So just to show you the area ni, kita panggil DWI on MRI. Okay, B1000 to be exact, and then this one the ADC, and then bila flare tu dia macam biasa je, normal. So meaning this one is mismatch. And then because this one is the MRA, gambar tak cantik because patient I think move in that time, but you can see dia macam, this one nampak full length of the this one is the left MCA, this one is the ACA, and then you can see the carotid artery. Okay, but this one you don't see it. So that area, and then we do, not every patient we do this lah kan, ni volume estimation lah. We can do some volume estimation, meaning volume dia dalam 52 cm. Okay, kita tak terlalu besar, tak terlalu kecil. Kalau more than 120, selalunya kita tak buat juga because it's too big, and then patient can get this reperfusion injury afterwards. So and then okay, to show you this one, kita punya cerebral angiogram. Okay, the stop shot there. Okay, and then kita buat thrombectomy and then post thrombectomy. So macam okay sikit lah. So this is the thing that we retrieve lah. I mean this is the stent retriever to retrieve the blood clot. So this is the harga ni I think 12,000 lebih lah, 12,500. Slightly but total the patient has to fork out back on 25,000 for this procedure lah. So this is the post angiogram. So but you can see some occlusion overnight sangat that area. And then this one normally kita buat MRI ni day 5 after thrombectomy tu. So kita akan buat lah. I mean this is our protocol here. Tempat lain maybe lain. So okay. So just to show you, sometimes we can see, like this one is what we call ICAT lah. Intracranial atherosclerotic disease, ICAT. So dia macam sakit jantung jugalah. You can see the blood build up. So This one after the angiogram, you notice. But we didn't do anything because the flow is quite good, tak ada apa-apa. This is one of our first few cases from private. And then this is again angiogram on the left side. Okay, ni mata left side, ni right side, and then this one left. Right, always this side. So if you notice this angiogram, this is our catheter there. And then again, this one stent retriever. Sometimes we call cord retriever kan. The banyak bintik-bintik ni is because of the marker of the stent. Tapi this stent is not like cardiology stent yang we can detach. There are only one manufacturer that dia punya stent boleh detach for purpose of stroke clot. Stroke through mechanical thrombectomy. Dia punya stent is not detachable. Okay. So during the procedure, and then so you can see some sort of lepas kita buat thrombectomy, still ada some sort of stenosis there. And then bila kita buat, and then you see dia punya flow. The good thing about this angiogram, because we can see the punya thing real time, so we know punya flow dynamic tu slow ke high flow ke, or like this one is not enough for the brain. Okay, then again, and then we put stenting and then we put a stent, permanent stent over there. So this is the final run lah. And then you can see the brain nampak cantik je kat atas tu. Okay. For your anatomy sake kan, I takut you all dah lupa probably, unless you have a very good photographic memory, mungkin you can ni kot. Okay. Okay, yang ni, this one what we call MCA, and then this one what we call A1, ACA. Yang pergi tengah tu ACA, and then this one is MCA. So this one what we call MCA occlusion just now. Okay, yang stenosis tu dekat in carotid artery, quite distal. Alright. This one I forgot what about it. Some Merdeka thrombectomy 69. Okay, NHS quite high, 15. Like I said, 6 is our macam cut-off point to intervene, and then you start to see like this, macam abnormal area, and then this is one we call SWE, susceptible weighted image, and then macam a lot of deoxygenated blood. Okay. And then once you do MRI, you don't see the M1, MCA ni, M1 dia tak nampak. Okay. This one, dia punya A1 dia, maybe you don't see it. Not sure why. Sometimes they can derive from the other side, alright? Or because sometimes it can be hypoplastic as well. So this is another gambar. This is react. Okay. This is the angiogram. Our catheter kat bawah, you don't see. So kita baru nak pre-plan where exactly the okay, you start to see that. You don't see the M1 just now. Okay, just like our MRI tadi. And then this one already there. This is our this is another method that we call aspiration technique. Sometimes we can tolak je our catheter at that area, and then we aspirate. Along the way tu kita aspirate. And then sometimes the clot can goes in, or dia macam get attached to the clot ni, they attach the tu, and then when we get the negative pressure, you can imagine kan, clot tu tertarik sekali, and then we bawa keluar lah. Right? Okay, afterwards nampak cantik je lah. This one is the cheapest one lah. 7,500 je. So pre and post lah. This pre and then post. Kalau dah macam gini ni, selalunya kita dah quite happy lah. Sebab sometimes when we intervene more, dia dapat spasm and all. Over the time dia akan improve lah. Okay, we go to the some other pathological stuff lah. Just now it's about stroke, ischemic stroke. Only ischemic stroke. Stroke can be, there are the two components. One is bleed, and then one is ischemic lah. The thing that we can maneuver is the ischemic stroke, and then it's caused by large vessel occlusion. Small occlusion tu kita tak boleh nak buat lah as a radiological part. Tapi for our neurologist punya colleague, they can give some apa tu nama, EVT, thrombolysis drug. Okay, we go for this intracranial bleed. I think you all know kan, extradural like this, biconcave, and then subdural concave, and then intraparenchymal bleed, and then subarachnoid bleed. Dia akan insinuate this along the what you call that, gyrus, along the space. Okay, so this is the basic I think you should know by now. So again, I shall just to show you, this extradural bleed. Most of the time is caused by trauma. Trauma selalunya extradural bleed. Subdural bleed occurs either, sometimes we can see in NAI, non-accidental injury. Selalunya kita panggil NAI ni, non-accidental injury ni, dekat pediatric lah. Pediatric meaning dia being abused. Sometimes dia gerak-gerak dia subdural bleed happens when the vein get injured inside, and also orang tua, sometimes orang tua can got this kind of bleed. If you notice kan, dia punya bleed ni, dia punya collection ni is hypo, right? So it's because it's already chronic more than 24 days or 30 days. So dia jadi macam ni. Tapi still you can see the collection there. Alright. This is intraparenchymal bleed. Normally seen in few occasions, tapi most of the time from our experience is hypertensive bleed. Okay. But it also can be caused by macam angiopathy, macam CAA, what we call amyloid angiopathy. And then satu lagi yang quite ni is hypertensive angiopathy pun also can cause bleed, right? And also vascular malformation, arteriovenous malformation also can cause bleed. Tapi arteriovenous malformation selalunya bleed dia quite besar lagi, and quite raw lah. And then this just to show you the bleed at the basal ganglia, and then the extend into the intraventricular side. This kind of bleed carries poor prognosis. Because the brain will be swollen. Ni dah start the swelling of the brain ni, and then midline shift, and then the later on patient can get hydrocephalus because of sebab dia punya hematoma component can can obstruct the CSF punya flow. Okay? Faham kan? Faham? Dah tertidur ke, Yul? Okay kan? Respon?
Okay.
Alright. Okay. So, most of the time, if you want to see bleed, CT scan is enough lah. For CT brain, so far dia macam pergi rumah jiran pakai kapal terbang. Quite difficult. Unless macam small bleed like this, we do lah. Macam what I mentioned just now, amyloid angiopathy tu, all the angiopathy, macam hypertensive angiopathy and amyloid angiopathy, or carcinoma small kan, kita akan use MRI. Kalau let's say there's no intraparenchymal, large intraparenchymal bleed or traumatic bleed, we don't use MRI because you see over time the what they call that, they're different in nature, so it may cause confusion to us because the time we don't know the time unless the patient gives a specific time, the bleed, the trauma, blah blah blah. Okay, and then this one is subarachnoid bleed. Like I said, the bleeding inside the intraparenchymal, the subarachnoid space, the CSF space, so they can insinuate along the side, and then like this one most of the time is because of aneurysm lah. Kalau nampak macam ni, you dekat, when you become a houseman somewhere, kat mana houseman, Limbang ke, and then there is a CT scan in Limbang. Last time when I was radiologist in Kuching 2008 2009 tak ada lagi. So Limbang now ada CT scan, now Malaysia very canggih one. So most of the time is aneurysm, and then you must do a CTA, we call it CTA angiogram, and then we can see the aneurysm, cerebral aneurysm. Most of the time, the most common site is this area lah, ACOM aneurysm. Macam case ni, I think ACOM aneurysm. Alright. ACOM meaning ni anterior cerebral artery, ni both anterior cerebral artery, dia ada communicating artery ni. Okay, this one selalu dapat. Alright. Okay, trauma. I think it's quite straightforward. Impact, if the impact like this, and then the injury is like this, is cool, and then however the impact to the other side contra cool. So sometimes the bleed is at the both side, bukan depan je, belakang pun ada. Most of the time, bukanlah most of the time, I think around 20% kot, if I'm not mistaken. The patient got head injury because of motor vehicle injury. For example, the head hit the dashboard or the steering wheel, and then sometimes the patient can get this sort of injury. Alright. Just to show you the aneurysm punya classification, the what we call short neck and then wide neck. Wide neck ni bila dia punya neck of aneurysm tu besar lah, and then the treatment is different. So macam wide neck ni, the best treatment is either surgery, they do clipping, they clip this thing kan, the clip je, pop, settle, or kita boleh buat, kita masukkan catheter, small catheter, we coil, at the same time kita ada balloon assisted, kita letak balloon just to make sure coil inside, or if let's say we want to coil tu the rupture, pop, kan, the rupture perforate, and then we can stop the bleeding lah. I mean for a while, temporary, and then at the same time kita boleh continuing coiling to one lah, right? Okay, like this one is what, this gambar from the internet. I tak sempat nak ambil our gambar, so so this is again, this one, like I said, this one is ICA all the way sampai dia bifurcate into this one A1 or ACA kan, anterior cerebral artery, and then this one MCA. So kita boleh coil dia lah. this aneurysm. This one, like I said just now, one of this cause of intraparenchymal bleed, this AVM. This one is arteriovenous malformation, meaning dia ada artery component, there's artery feeder, dan dia ni one big feeder ni. Ni paling besar ni, feeder dia satu, and then dia ada satu lagi feeder ni. I think daripada sini goes towards the lower feeder. This one I'm not sure. Ni another feeder or what. So, and then this one is the venous component. So selalunya dia ada what we call nidus. Dia nidus tu dia bukan normal. Okay, like nidus like this. Dia is not a normal tissue anymore. It's just macam tissue penghubung in between, this this AVM. So this one we can safely embolize. Embolize using like this one. This one what we call serpiginous. Dia macam ni. Kalau you nampak macam ni, flowoid pattern, and then like a serpent, banyak beberapa ekor serpent or cacing worm like. So this one is most exclusively AVM arteriovenous malformation. Whatever sequence. Okay. Kita ada beberapa basic sequence yang you should know. Like this one is T2, and then T1. I tak sempat nak tunjuk dalam ni. Alright, tak apa, terlupa. Okay. So, again this one AVM, and then the treatment. This one the treatment we use macam, unlike kita buat thrombectomy, this one is different. Kita nak tutup darah, so what we call embolic fluid embolic particle macam ni. This one what we call fill. Dia akan keluar macam foam gitulah, lava macam coklat lava yang you all like tu kan. So macam tu lah. And then the best thing, they just flow like lava. Dia tak go through and beyond. They relax. Okay, and then we go to neurodegenerative disease. It's quite, I know it's quite boring for you guys, but I think most of our customer for CT MRI brain is because of this Alzheimer's disease. Sad to say, but that's the thing. So again, assessment of dementia. If you get I think quite rare you get a dementia for long case. Never mind. So kalau let's say for me, the first thing I want to see Alzheimer is this area lah. What we call parietal atrophy. Dia macam eksklusif sikit lah untuk Alzheimer. Okay, like this. I don't think you need to know all this lah, macam banyak sangat. This one maybe neurologist level lah, right? So Fazekas ni just to show you the white matter because of degenerative disease lah. Okay. Most of the time we see on flare. Flare ni sama macam T2. T2 tu itulah show you later on after I finish this one. Nanti you ingatkan I lah. So T2 fluid is bright or hyper intense. Kalau let's say CT scan we call hyper dense, okay? Kalau MRI we call hyper intense. So this one is flare images, meaning dia T2 base, meaning suppose yang dalam ni, the lateral ventricle ni supposed to be bright, tapi dia kita invert dia. So dia tak ni lah. So only the abnormal fluid that we can see macam ni. Okay. Then we go quickly to the intracranial tumors, adult and pediatric, and paling banyak kalau primary in adult is gliomas lah. Ini kita panggil primary brain tumor. And then the most notorious, the most common, sadly, the most common is GBM, glioblastoma multiforme. Multiform, belakang dia multiforme. Maksudnya dia ada banyak form. Dia ada bleed, dia ada cyst sometimes. Dia not all solid. That's why the name like this. And then WHO already grade dia ada grading dia lah for glioma ni. Tadi kan I mention about glioma, dia ada grade dia 1, 2, 3, 4. Do not attempt to to remember this, no point, but try to remember this at least GPM. Alright. Dia punya survival rate dia 10% saja, 5 years. Meaning after 5 years, if you see 10 patient, adalah 1 orang je yang hidup. Faham kan? Hello? Alright. And then this one just to show you lah, dia punya type macam globulin. GBM tu very nasty looking. Kalau yang lain-lain tu macam ni kan, yang asal grade 2 ni macam iya ke tak vision ni kan. Macam ni pun macam tak very bright, but this one very bright. And then meningiomas, meninges kan, I think you all learn about meninges kan, DAP, Dura, Pia, apa semua tu kan, Dura. So meningiomas ni dia develop from meninges. So slow growing, benign, but dia causing compression symptoms. Kalau dia besar sangat like this. Patient most of the time kalau dekat frontal region macam ni, dia present with some, kalau left side dia ada macam cognitive impairment, and then some inhibition, macam kencing susah. Kencing bukan susah, tak boleh control, things like that. And then one peculiar things about, one quite pathognomonic juga for meningioma is what we call duratale ni lah. Because it's from the meninges kan. So dia adalah sikit macam thickening, so like this. And then this usually selalunya hyperintense or on CT dia bright because of the punya cellular component tu, dura punya cellular component tu, dia very packed. So that's why dia jadi macam tu. Alright. But of course dia ada variation juga, dia ada variant. Dia ada yang cystic, ada juga yang vascular punya area dia. Bila vascular ada a lot of flow void. Flow void in an MRI terms just now, if you notice yang ni, okay, kita panggil flow void ni is exclusively because the MRI cannot capture the image. So you must remember kan, bila kita buat MRI tu, patient must be static, tapi dalam ni dia bergerak. Bukan dalam, dia punya blood flow. So this one what we call flow void. So vascular is flow void. So that's why kalau let's say this one macam you nampak dot void ataupun spinginess sikit-sikit, and then this one probably reach of this meningioma is atypical. Sometimes dia panggil hemangioendopericystoma. Itu dah lain-lain sikit lah. I think quite difficult. For you guys, I think just know that glioma, meningioma, tu dah ciri cantik lah. And then pituitary tumor. I think this one quite glamour for your all punya ni lah. Macam yang prolactinoma, and then the, what we call that, yang producing ACTH punya, and then can cause Cushing syndrome, primary tumor, primary Cushing kan, or secondary Cushing, so cannot remember. Okay, first regarding pituitary tumor ni kan, of course it's developed from the pituitary gland. Okay, and then most of the time is macroadenoma. Dia not secreting anything, tapi dia compressing. You must remember, nampak tak kecil ni? Ini supposed to be ada optic nerve, optic chiasm. This one supposed to be optic chiasm. So dia macam optic nerve tu dia pergi ke depan, and then dia akan berselirat tengah-tengah tu jadi optic chiasm, and then dia compress, and the patient may get, some sort of mata tak apa nampak lah. And then by definition 1 cm is macroadenoma. And then microadenomas, some are producing hormone, some are not producing hormone. And then these are the hormone that they are producing. Growth hormone ni almost jarang I jumpa. Tapi yang selalu these two ACTH producing hormone causing Cushing, and then proactinomas lah. Dia akan causing irregular menstrual cycle, lepas tu breast milk production and infertility. In men, decreased sexual drive, and then erectile dysfunction. Okay, for the pituitary yang normal kan, okay, nah this one I said, optic chiasm atas ni, pituitary gland macam ni je. And then you still remember the flow void I mentioned to you? Okay, the flow void, this one is the ICA punya flow void. ICA, internal carotid artery punya flow void. Sama like this. This one flow void. This one flow void. Okay. Okay, this is the pituitary gland, the normal one. And then this is the stalk. This one dia betul dia ambil gambar. I mean the cut at the stalk area lah. Kalau tak you tak nampak pun. Alright. Okay, and then you must give contrast lah to know. This one non-contrasted. See, this one is T1. This is a T1 image macam ni. T1 grey matter kan, grey kat luar kan, grey is grey, white is white. Okay, this one is T1. Okay. Dengar tak? I mean, you all faham Faham? Alright?
Alright lagi, doktor.
Alright lagi Cakap kalau dah ngantuk sangat, dah bosan, beritahu lah. So this one what we call microadenoma. Kecil je. Alright? Dia after we give contrast, it doesn't enhance. Pituitary gland supposed to be enhanced. Pituitary macroadenoma dia late enhancement atau dia tak enhance langsung sampai tu. Tapi of course lah, sometimes walaupun dia producing hormone, alright, sometimes dia very small, even kita punya cut tu pun tak nampak. And then normally kalau macam tu kan, kita boleh buat satu lagi, kita panggil IPSS, inferior petrosal sinus sampling. Tapi I'm not sure whether you have to know about this, takut you're all confused. Tapi basically we want to see which area dia punya problematic. Kita ambil sampel darah from this side of brain kan, kita nak tahu this or this, sebab di half cut of the patient wants treatment. Okay. And then schwannoma daripada Schwann-Stell yang yang produce myelin that insulate nerves lah. Okay. Macam ni. Yang paling glamour selalunya acoustic neuroma lah. Okay. This one is benign tumor. Dia tak macam yang lain-lain. This one pun benign lah. Lupa nak cakap kat you guys. Jarang I so far tak pernah jumpa pituitary yang malignant so far. Meningioma is most of the time, almost 95% is benign. And then yang ni yang I cakap tadi lah, astrocytoma, dia ada 4 group. You have to know yang GBM tu, glioblastoma multiforme. Okay, and then acoustic neuroma, atau sometimes people call it vestibular schwannoma. Okay, the appearance like this. This one after we give contrast, the gadolinium uptake of the acoustic neuroma tu. Dia bukan malignant tapi dia compressed. Patient may have, what do you call that, tinnitus, and then, imbalance. and sometimes patient can get weakness also kalau ada compressed pons. Pons ni ada what do you call that, ada track, ada what you call motor cortex track tu, so takut dia boleh compress also. And then we go yang malignant, of course, metastasis lah. Lung cancer is the most common type. The lung cancer can be anything. Okay, dia punya appearance dia macam-macam. Ada yang solid, ada yang pseudo solid. Tapi I will show you later on. Melanoma ni dia quite characteristic because dia hyperdense because the material tu dia punya cell tu dia rapat, and then dia jadi macam hyperdense. Sometimes dia can cause bleed juga lah. So we're not sure either dia you know, because of their it is compared with cells or okay. Meds sometimes bukan sometimes, most of the time dia ada vasogenic edema. Vasogenic edema means that the patient, dia ada dua jenis edema, right? Cytotoxic edema, one normally you see in stroke. Cytotoxic means cell death, dia tak cukup oksigen, dia mati. Okay. Vasogenic edema means dia ada what do you call that, capillary vessel tu dia ada defect. Blood-brain barrier, so they become permeative, so a lot of fluid coming in because of inflammatory reaction or whatever. Okay, so vasogenic edema. The thing that can cause vasogenic edema, you need to remember dua je, metastasis dengan infection or inflammatory lah. So kalau let's say cytotoxic tu cause dia lagi sikit. Most of the time because of stroke. Or stroke lah kot. Okay, this one is a pediatric age group brain tumors. Ni pun akan menyebabkan you opening juga, tapi I hope you can stay. Alright. So okay, craniopharyngioma. Dia ni actually embryonic tissue remnants okay, pouch and also craniopharynx punya remnants tissue. Okay, mostly dekat area tengah-tengah ni, sella area, the area of pituitary gland ni. So kalau you nampak macam ni, area pituitary, pediatric, this one is pituitary tau. Nampak yang kecil ni? So, this area, alright? Craniopharyngioma, and then the appearance because of the blood and all, the bleed sikit rupa dia. Yeah. And then germ cell tumor, this one almost germ cell ni dia dekat midline structure tau. Daripada brain sampai ke bawah. Tapi bila kita sampai brain pun dia you know, dekat area of pineal gland ni. So germ cell, only remember the midline structures, right? And then medulloblastoma, they can be anywhere, tapi again banyak yang I tengok pun dekat tengah-tengah lah, dekat medulla. So the blastoma, medulloblastoma. And then we go to demyelinating disorder. Ini pun I'm not sure whether you need to know this. Tapi kalau you tengok TV, tiba-tiba patient tak boleh angkat lah apa semua kan. Paling most common yang ni lah, multiple sclerosis. Multiple sclerosis, I tak tunjuk pula dia punya gambar. Tapi multiple sclerosis ni is macam again myelin. Okay, this one is the inflammatory disorder. Inflammatory disorder. Okay, lupa tadi, I got distracted. Multiple sclerosis, selalunya dia ada what we call macam on T2 dia slightly bright lah. I'm not sure you have to know this. Susah lah, I think. And then yang you should know, I think encephalitis lah. Encephalitis meaning brain got inflammation by viral, by most of the time is by viral lah. Macam ni HSV herpes simplex virus dia quite common dekat area sini. Dekat area temporal pun. Herpes simplex virus. I think you remember satu je pun cukup enough lah. Ni herpes encephalitis around this. And then they use acyclovir, antiviral therapy, and then they start to regress, right? Bakteria boleh, tapi tak. So far Lyme disease saya tak pernah tengok. Okay. Cryptococcus neoformans selalunya dia macam not become encephalitis. Tapi itulah most of the time because this. And also toxoplasmosis. Toxoplasmosis and malaria. Okay. Sometimes autoimmune also can cause encephalitis. Encephalitis ni dia just dia swollen up, tapi dia tak ada banyak sangat vasogenic edema, dia tak ada banyak sangat cytotoxic edema. Dia just encephalitis, dia just inflammation, tapi dia akan regress balik lah. Alright. And then meningitis. Okay, meningitis is quite common. This one plain, this one is with contrast kalau you perasan. And then when you give contrast, dia akan lighten up. All the vessels, the vessels of the meninges. Not to say capillary, tapi the vessel of the meninges dia akan lighten up. So causes dia banyak lah. Most of the time our staph dengan streptococcus dengan staphylococcus. Viral meningitis also, itulah kita tak boleh nak differentiate between these two. Alright. And then brain abscesses. Like I said, the vasogenic edema tu banyak ni. Alright. And then there is some fluid macam appearance like this. Kalau you tengok macam ni lah. Alright. Again dia punya ni yang banyak pun streptococcus and staphylococcus. Right. Torso, yes. Torso I've seen few. Toxoplasmosis ni. Dia quite distinctive. Toxoplasmosis ni macam ring enhancement, macam very bright. Once you see it, then you don't forget. Right. Okay, we go to the cranial bone lesion. Basically macam osteomas, osteosarcoma. I think osteosarcoma is malignant, osteomas is benign, fibrous dysplasia, meaning that your bone tissue tu dia being replaced by fibrous. That's all. Itu je. Causes unknown. Cardiac disease pun sama juga. Bukanlah sama, meaning causes is unknown, tapi the remodeling problem dia macam you bone tu every not every day over time our brain our bone tu they gets remodeled, and then this is the abnormality the remodeling. And then chordoma, multiple myeloma is the is again cancer juga, but because of sorry, get distracted again. Multiple myeloma, plasma cell punya cancer lah. I go one by one. Chordoma is a tumor. Tumor centrally located and then mainly at the clivus. Alright, this one is the clivus. Clivus ni macam part of the bone. Base of skull tu dari satu tempat macam dia macam bentuk macam C shape so clivus macam chordoma. Chordoma yang family yang glamour dekat clivus and then dekat sacral bone. These two sacral bone, tapi our topic is say NS, so clivus lah. I'm not talking about the sacral bone, right? And then multiple myeloma, this is macam punch out lesion macam ni. This one is what we call punch out lesion. Ni nampak clear sikit, alright. And then they involve the diploid space. Diploid space, dia punya periosteum ni kan, outside ni periosteum, ada 2 periosteum. It's quite normally intact. Like I said, dia because of plasma punya problem, plasma punya tumor. So the appearance like this, something dia panggil, I forgot what it's called. Paper pot, if I'm mistaken, right? And then this one is osteoma. It's benign at the cortex. This one paper pot skull, dia sama je. Paper pot skull. Because of patient with hyperparathyroidism, PTS is high, and then calcium also high, and then the bone resorption ada problem lah. So they become swollen, swell like this, and then this one is quite distinctive. You nampak sekali, you tahu this one hyperparathyroidism. Actually dia dengan Paget's ni macam sama, tapi the cause is different, right? This one Paget disease, macam I cakap tadi, abnormal bone remodeling. So dia jadi macam cotton wool appearance, macam ni, macam cotton wool, right? Okay, we go for fractures. Most of course, dia kalau let's say fracture skull ni, kalau frontal bone fracture, parietal bone fracture, occipital bone fracture. Dia guna nama macam tu je. And then extending from where to where kan, from where to where. And then if you got see fracture, you have to see intraparenchymal, you have to see dia punya whether any intracranial bleed lah. Why I want why I mention this is this Lefort nama French surgeon if I'm mistaken masa Napoleon War, if I'm mistaken lah, you Google balik. So dia ada fracture ni dia quite distinctive because fracture ni dia macam pecahkan your skull into beberapa segment, into 2 segment. Lefort dia just dekat your below mandible. I forgot this one, alveolar ni. So dia jatuh, dia boleh separate into these 2. Then Lefort 2. Tapi yang paling teruk Lefort 3 lah. You can imagine your skull to break up macam tu, right? Lefort fracture. It's quite common, quite common. Alright. Okay. This is the best for fracture, for bleed, CT scan. You remember this? You tak ingat dalam my lecture ni, for fracture and bleed, CT scan is the best to see. Alright. And also for calcification, CT scan is the best to see. Alright. So ni lah default fracture, from dia terpotong. So okay. Any questions so far from the third year?
Sorry, doctor. Fracture, bleed, and what is the other one, doctor, for CT?
Fracture, bleed, and calcification.
Thank you, doctor.
Alright, gitu. Okay, I dah janji buat nak tunjuk you MRI T2. I think you can see now kan? This one T1, this one T2. Okay, T2 dia macam CSF is bright. T1 what you call that, the grey matter yang kat luar ni grey, white matter is white. This one T1. And then flare ni dia invert, the inversion recovery, dia invert lah. Alright. Okay. Sama juga kalau dekat ni, dekat cervical area and CSF. Okay. Dan ni fluid, ada sikit fluid dalam kita punya disc tu. need this. Okay. So sama concept lah. This one T1, this one T2. Okay. All right. Any questions? Ada nak tanya ke pasal fiber ke, X-ray ke, tube ke? Tapi for your exam purpose, I think for third year tak banyak sangat keluar, tak ada banyak sangat keluar. Probably chest X-ray. Will be a lot of chest X-ray, maybe pneumothorax, things. For yang CNS, bit rare lah to us. Okay. Tapi for your final year, you have to know a few things lah. Macam yang bleed tu you have to know lah. Bleed, I think quite easy one. And then if let's say infarct, forgot to ni. Kalau infarction on CT brain, dia macam hypotense saja. Okay. Yang ni macam dah lama, ni cytotoxic edema macam tu. The whole ni kan M1 ni, the whole M1. ACA dengan posterior cerebral artery, PCA, ni ACA, okay. Ni MCA, ni besar ni, more than 120. So that becomes hypodense. Dia kalau lama sangat, dia akan jadi macam ni lah. Dia become void space. Alright. Ni kalau dah lama, over time, over 2 years, 3 years. Okay. Any questions? Ada tak? Okay. 56 people.
Okay, Doctor.
All right. Thank you.
Thank you, Doctor.
Thank you, Doctor.
Okay.